Hello everyone. In today's session, we are going to discuss about acute respiratory infection. It is a continuation to the chapter Epidemiology of Communicable Diseases. The objective to this session are definition, classification, problem statement, epidemiological determinants, which is nothing but the agent, host, and environmental factors, the risk factors to acute respiratory illness, mode of transmission, clinical features, clinical assessment, physical examination, the management, prognosis and complications, the prevention, followed by the immunization, and lastly, the general advice. Let's begin with the definition. Respiratory tract infection refers to any number of infectious diseases which are involving the respiratory tract. Very simple definition. What is respiratory tract infection? It is nothing but the number of diseases, the number of infectious diseases involving the respiratory tract. You can see the respiratory tract, which is starting from the nasal cavity, the nose, and ends into the alveoli. This infection is going to cause the inflammation of the respiratory tract anywhere from the nose to the alveoli with a wide range of combination of signs and symptoms. So these number of diseases will have its own symptomatic presentation. They have a wide range of the combination of signs and symptoms will be presented to us. Acute respiratory tract infection is an infection which is interfering with the normal breathing. This respiratory infection obviously is going to affect our breathing. It interferes with our normal breathing. It can affect just your upper respiratory tract, or it can also affect your lower respiratory tract. So we need to know what comes under the upper respiratory tract and the lower respiratory tract. The upper respiratory tract will start from your sinuses and ends in your vocal cord. You can see here, starting from the nasal cavity, or you can consider the sinuses here, the nasal cavity, then comes the pharynx, and the voice box or larynx is the upper respiratory tract. Then we move further to the lower respiratory tract. The lower respiratory tract includes the trachea, the primary bronchi, and the lungs, and the alveoli. Okay, the alveoli. It is up to the alveoli. So, the upper respiratory tract starting from the nasal cavity or sinuses up to the voice box or larynx, or just the lower respiratory tract which is starting from the vocal cords and ending into your lungs, that is the alveoli. This infection is dangerous especially in the children, older adults, and people with the immune system disorder. So the children, old age people, and those who are suffering with the immune system disorders, it could be the autoimmune diseases, or it could be the HIV, immunocompromised individuals. In these individuals, the respiratory tract infections are dangerous. The classification of respiratory tract infections. They are classified depending upon the site. We have already discussed the two sites. They are upper respiratory tract and the lower respiratory tract. Upper respiratory tract from the nasal cavity or sinuses to the larynx, and the lower respiratory tract is from the larynx to the alveoli. We see the nasal cavity to larynx, trachea to lungs. Now we are going to discuss further about the upper respiratory tract infection. The upper respiratory tract infection is a part of, I have just put a slide where you can clearly remember the differentiation between the two, the classification. Clear? The classification We'll just have a quick look at the classification, upper and lower. So now we are going to start discussing about the upper respiratory tract infection. The typical infections of the upper respiratory tract we will discuss in the next slide. So the upper respiratory tract is a part of the respiratory system which lies above the trachea. It includes the nasal cavity, pharynx, larynx. Okay. And what are the infections which the upper respiratory tract includes? Beginning with the nasal cavity. In the nasal cavity, you can remember the common cold. Then comes pharynx. Pharynx, we have pharyngitis. And then there is rhinitis. And otitis media, the middle ear infection, is also known as otitis media. Rhinitis, it is nothing but a medical term for the inflammation of the mucous membrane in the nose. The common cold, rhinitis. Then we have pharyngitis, tonsillitis, laryngitis, sinusitis, and influenza. What is influenza? Influenza is a viral infection which is affecting the nose, throat, bronchi. Sometimes it also affects the lungs. Okay, nothing but the patient will present with fever, malaise, headache, non-productive cough, rhinitis, sore throat. So the upper respiratory tract is mostly involved in influenza. Is it clear? The upper respiratory tract infections, you can start from the nose, common cold, rhinitis, and then in the ear, otitis media. Then you come to the throat, tonsillitis, pharyngitis, laryngitis, and then here sinusitis, influenza. Okay, in the nose you can remember these three. It's clear? Yeah. We move further. The lower respiratory tract infection. We are discussing about the classification. The upper respiratory tract infections are done. Moving further to the lower respiratory tract infections. Any infection in the lungs or below the voice box. So the division, the classification, and what are the parts which are falling under the upper respiratory tract needs to be very clear. Now moving further to the lower respiratory tract, anything below the voice box or the larynx is constituting the lower respiratory tract. And the infections which are seen in the lower respiratory tract are pneumonia. Okay, first we have pneumonia, in which the air sacs or the alveoli in one or both the lungs may be filled with fluid or pus. And then we have bronchitis and bronchiolitis, followed by tuberculosis. Four things you have to remember: pneumonia, TB, pneumonia, bronchitis, bronchiolitis. You can remember like this. Okay. Oh, sorry, there's something wrong. Okay, fine, let's continue. So how do we remember now? We have pneumonia and TB, pneumonia and TB, bronchitis and bronchiolitis. These are the lower respiratory tract infections. Now what is bronchitis and bronchiolitis? How do we differentiate between them? Bronchitis is inflammation and swelling of the bronchi, whereas bronchiolitis is the inflammation of the bronchioles, which is usually caused by a virus. It is the most common lower respiratory tract, which is seen especially in the children who are less than 2 years of age. You see this bronchiolitis, which is the inflammation and swelling of the bronchioles. Let me zoom into the picture so that you can have a better clarity. So you see here bronchitis. You can see the bronchitis in different color. Yeah, bronchitis. It is the inflammation and swelling of the bronchi. You can see the bronchi being involved here. Now comes the bronchiolitis, where the bronchioles are involved. Inflammation and swelling of the bronchioles. Here the bronchi. You can see the division bronchi, and further the bronchioles are involved. So it is bronchiolitis and this is bronchitis. In pneumonia, air sacs will be filled with fluid or pus. Then we know TB, typical presentation, which we will discuss in detail in the upcoming videos. Moving further, the most children with these infections have only mild infections like cold or cough. However, some children may have pneumonia, which is the major cause of the death in the children. Okay, pneumonia is said to be one of the major causes of the fatal, the rate being increased in the newborns. In less developed countries, measles and whooping cough are also an important cause of severe respiratory tract infections. Now, coming into picture are measles and whooping cough. They are also constituting one of the important cause of the severe respiratory tract infections, especially in the less developed countries. We see in the less developed countries. When we discussed the whooping cough, we studied in the previous session. We studied that whooping cough is more in the underdeveloped countries, less developed countries, it is seen to be more. The incident rate is high. Moving further to the problem statement. Of the estimated 5.83 million deaths among the children less than 5 years of age globally, in 2015, 0.294 million were estimated to be caused by pneumococcal infection. So they have estimated that 5.83 million deaths are seen in the children who are less than 5 years of age. You see, the children who are less than 5, okay, they less than 5 years of age. This child estimated of this age, the children estimated 5.83 million children were estimated to be experience death globally, and this 5.83 million, out of these 0.294 death were recorded due to pneumococcal infection, that is due to pneumonia. An additional 23,300 deaths were estimated to have been occurred in the children who were co-infected. Along with the pneumococcal infection, they were co-infected with HIV. Disease and mortality rates are higher in the developing countries than in the well-developed industrialized countries, with most of the deaths are occurring in Africa and Asia. You see, in Africa and Asia, we have most of the deaths occurring, especially in Africa and Asia, we have the fatality rate to be high. Before the widespread introduction of PCV, that is pneumococcal polysaccharide conjugate vaccine, into the national immunization program since 2006, the reported mean annual incidence of invasive pneumococcal disease in the children less than 2 years of age was 44.4 per lakh population per year, especially in Europe and United States of America. 60 per 1 lakh population is seen in South Africa, and somewhere in between this in Asia and Latin America. So we see before the introduction of the vaccine, before the introduction of the PCV vaccine in the program, in the national immunization program, there was an annual incidence of the disease about 44.4 per lakh population per year. 60 per 1 lakh population in Africa, and somewhere between these in Asia and Latin America. In India, in the states and districts with a high infant and child mortality rate, acute respiratory infection is a major cause of the death. We see in India, in the states, in the districts, ARI, that is the acute respiratory infections, is a major cause of the death. ARI is also one of the major reasons for which the children are brought to the hospitals and to the health facilities. You can see in the pediatric OPDs and IPDs, children being admitted with pneumonia, that is a lower respiratory tract infection, and children coming to the OPD basis. Majority of the children coming to the health facilities, coming to the hospitals are the children brought because of the ARI. Hospitals records from the states with a high infant mortality rate show that up to 13% of the inpatient death in pediatric ward is due to ARI. So out of all the children who are admitted in the pediatric ward, most of the deaths, that is up to 13% of the IPD deaths in the pediatric ward, the cause of the death will be recorded as ARI. And this is seen in the hospital records where those states which are recording the high infant mortality. The proportion of death due to ARI in the community is much higher as many children die at home. We see that many children are not brought to the hospitals, to the health facilities because of the low socioeconomic status, negligence, lack of knowledge. Children are not brought to the hospitals. In fact, much higher children are being dead at home. The reason for high case fatality may be that children are either not brought to the hospital or they are brought too late to the hospital. In India, during 2018, about 41 lakh 6,260 cases of ARI were reported with 3,740 deaths. So we see that in India, during 2018, the cases of ARI were very high and the deaths were also recorded. Same year, 9,28,485 cases of pneumonia were reported with 4,213 deaths. So the 2018, the peak was too high, the mortality rate was high, the incident rate, the cases were too high. So we see the cases are 4 crore 19 lakhs 96,260 cases. Moving further to the epidemiological determinants, we have the agent factor, host factor, and environmental factor. Agent factor is the bacteria, which is Bordetella pertussis, Corynebacterium diphtheriae, Haemophilus influenza, Klebsiella pneumonia, Legionella pneumophila, Staphylococcus pyogenes, Streptococcus pneumoniae, Streptococcus pyogenes. And we also have a picture of some of the bacteria here. So what are the agent factor? The causative agent of the acute respiratory infections is the bacteria. And then in the next slide we have the viruses. So the agents are bacteria, virus, and we have few other agents. So I hope the bacteria are clear to you. What are the bacteria? Bordetella pertussis, Corynebacterium diphtheriae, Haemophilus influenza, Klebsiella pneumoniae, Legionella pneumophilia, Staphylococcus pyogenes, Streptococcus pneumoniae, and Streptococcus pyogenes. Moving further to the viruses, we have adenovirus, enterovirus, echo and coxsackie. Under the adenovirus, we have endemic types which is 1, 2, and 5, and epidemic types are 3, 4, and 7. Influenza virus A, B, and C, measles, parainfluenza 1, 2, and 3. We have the parainfluenza type 1, 2, and 3, respiratory syncytial virus, rhinoviruses which have the multiple serotypes under it, and lastly the coronavirus. Can you just quickly memorize the viruses? What are those? Adenovirus, enterovirus, influenza, measles, parainfluenza. You can remember it like adenovirus, enterovirus. Adeno and entero together. Measles and influenza, they are adding on. So we have measles, influenza, parainfluenza, rhinovirus, coronavirus, and respiratory syncytial virus in the last. Clear? What are those? Adenovirus, enterovirus, we have measles, influenza, parainfluenza, rhinovirus, coronavirus, respiratory syncytial virus. The other agents include chlamydia type B, psittacosis. So the psittacosis is also known as the parrot fever. We know the chlamydia type B. The picture is given here. The chlamydia type B. It is also known as parrot fever. The psittacosis is also known as parrot fever, or it is also called the ornithosis. Yeah, it's ornithosis, which is a zoonotic disease, which is caused by the chlamydia psittaci. It is usually transmitted to the humans through the infected birds like the poultry, parrots, and it can be contracted by inhaling those dried droppings, the feather dust, or the respiratory secretions of the parrot. It is transmitted to the humans through the poultry. And next we have Q fever, which is caused by the Coxiella burnetii. So the Coxiella burnetii causes the Q fever. It is caused by the bacterium Coxiella burnet, which infect the humans, cattle, goat, sheep, and many other mammals like ticks, birds, reptiles as well. And we also have the Mycoplasma pneumoniae, which is causing the pneumonia. Moving further to the host factor. Small children can succumb to the disease within a matter of days. So, what is succumb to the disease? They can yield to the infection, yield to the disease. They are very much yielding to the disease within a matter of days. Case fatality rates are higher in the young infants and the malnourished children. We saw one of the high risk people are the young children, immunocompromised individuals, and older aged people. To begin with, under the host factors, the age specific mortality rates show a wide differences between the countries. We saw in Africa, Asia, and there was a difference in the numericals, the difference in the rates. In general, the rates tend to be high in the infant and the young children, and especially in the elderly in all the countries. Something remains universal in all the countries, that is mainly affecting the children, young children, infants, and the elderly. Upper respiratory tract infections like the common cold and pharyngitis are several times higher in the children than in the adults. The upper respiratory tract infections, what are those we studied? The common cold and pharyngitis. They are again higher in the children compared to the adults. The rates for the pharyngitis and otitis media increases from infancy and reaches to the peak at the age of 5 years. So the pharyngitis and otitis media, acute otitis media, which is the infection of the middle ear, which results because of the respiratory tract infections or a sore throat, tonsillitis, and the patient will present with the earache or the hearing loss, acute hearing loss. So this is mostly seen in infancy, and the peak is seen at the age of 5 years. Illness rates are highest in the young children, and they are decreasing with the increasing age. So as the as the age increases, like the person's turning into an adult, so when we consider the adults, the respiratory tract infection decreases because of the development of a better immunity. Except in the third decade of the life, when the young adults are exposed to the infection by their own young children. So if the young couples are having those young children, and those children can get the respiratory tract infections from their schools, and the mothers can get infected, their fathers can get infected. So the parents are getting infected from the young children. Generally in adults it is less, the incident rate is less. The incidences are only seen in that young age group, nearly 30 age. Around that age, they are getting the acute respiratory infections from their children. The agent which is causing the acute respiratory infection, the age group which is commonly affected, and the clinical feature of each of this. So the Bordetella pertussis, it is mainly affecting the infants and young children, and the patient presents with paroxysmal cough. Cornybacterium diphtheriae, we have discussed about the diphtheria in detail in our previous slides. So the Cornybacterium diphtheriae mainly affects the children. The patient can present with the membranous exudates, that is nasal membranous exudate, tonsillar membranous exudate or pharyngeal membranous exudate, it can be or not be associated with toxemia. Haemophilus influenza mainly affects the adults, and there is an acute exacerbations of the chronic bronchitis pneumonia in them. It also affects the children. Haemophilus influenza affecting the children, causing the acute epiglottitis. Glottitis. Okay, there is epiglottitis. Inflammation of the epiglottis can be seen. There is an acute inflammation of the epiglottis resulting in acute epiglottitis. In Haemophilus influenza type B is mostly causing the acute epiglottitis. Klebsiella pneumonia mainly affecting the adults, causing the lobar pneumonia. The lobar pneumonia may be associated or not be associated with lung abscess. Legionella pneumophila is mainly affecting the adults, causing pneumonia. Staphylococcus pyogenes will affect all the ages, causing the pneumonia. It could be lobar pneumonia or bronchopneumonia, especially secondary to influenza. Primarily, the Staphylococcus pyogenes will cause influenza in the patient, and secondary to that, the patient can develop with lobar pneumonia or bronchopneumonia, or may not have a lung abscess. Streptococcus pneumoniae will affect all the age group, and patient presents with pneumonia, which could again be lobar pneumonia or multilobular pneumonia. They can also result in acute exacerbations of chronic bronchitis. The Streptococcus pyogenes will affect all the ages, causing acute pharyngitis and tonsillitis. Moving further to the viruses, the adenovirus, which have endemic type 1 to 5. How can you remember that? Endemic type 1 2, epidemic type 3 4, and under endemic we have 5 and epidemic we have 7. 1 2, down you have to write 3 4 5 and 7. The endemic types 1 to 5 will affect the young children especially, and presents with the lower respiratory tract infections. Epidemic types 3 4 7 will affect the older children and young adults, and they present with febrile pharyngitis and influenza like illnesses. The enterovirus will again affect all the ages, producing a variable respiratory infections. Influenza A B will affect all ages and school children, and they present with fever, malaise, variable respiratory infection, and occasional primary pneumonia, secondary bacterial pneumonia in elderly. The influenza type C is rarely affecting the individuals, and they will present mild upper respiratory tract infection. Measles will obviously affect the young children, and they will present with variable respiratory with the characteristic measles rash. Parainfluenza type 1, 2 and 3. 1, 2 will affect the young children, and they will present with croup. Reinfection can also occur in the later life. The mild upper respiratory infections are seen. The parainfluenza type 3 will affect the infants, causing bronchiolitis and pneumonia. Respiratory syncytial virus will affect the infants and young children, causing severe bronchiolitis and pneumonia. Rhinovirus, which are the multiple serotypes, and the coronavirus will obviously affect all the age groups. We have seen the pandemic occurring in our own country, and then it is affecting all the ages, and the patient presents with the common cold. The other agents which we studied are the chlamydia type B, psittacosis, the adults exposed to the infected birds, that is the parrots or the poultry. They present with influenza-like illness and atypical pneumonia. Coxella burnet, the Q fever, the adults who are exposed to sheep and cattle, they present with atypical pneumonia. Mycoplasma pneumoniae, it affects mainly the school children and the young adults. The patient presents with febrile bronchitis and atypical pneumonia. So why we went through the table is, so far the clinical features. If in your examination, if the question appears that write down the clinical features, the causative agent, clinical features, the epidemiological determinants, the agent factor, host factor, the environment, which we'll discuss in the upcoming slide. So now, so far, if they ask a question like write down the agent factor, host factors, that is the epidemiological determinants, and the causative factors and clinical features, you are able to tell a number of them. And since we went through each of the agent factor and its clinical presentation, you can write down all of it and you can fetch good marks here. That is the reason we went through the table. Specifically, each of the agent and each clinical presentation will not be asked. In general, you have to remember it. Moving further to the risk factors. Many risk factors for the respiratory tract infection have been identified. They include not only the climatic conditions but also the housing condition and the level of industrialization in that area, in that city, in that town, in that country, and the socio-economic development of that particular state. The other risk factors in the developing countries are the overcrowded dwellings. We saw the overcrowded dwellings and the underdeveloped areas, and then we have the poor nutrition. You can see the poor nutrition, out of which the babies born will be low birth weight, the lung capacity will not be well developed, and they will end up with the respiratory tract infections. And the intense indoor smoke pollution underline the high rates. Because of the indoor smoke pollution, they cause a lot of respiratory tract infections. Local mortality rates are particularly affected by the extent of influenza epidemics. So, the mortality rate, locally what they take, the rates will depend upon the epidemic, especially the influenza epidemic. Studies in the developed countries have shown that the higher rate of infection is commonly seen in the younger siblings of the school going children who will introduce the infection into the household. We see that the local mortality rates, they are seen by the influenza epidemics, and the studies have shown that the higher rate of infection in the developed countries, higher rate of infection is because of again the spread of the infection from the school going children to their younger siblings, and they will also affect the older adults, that is their parents. Maternal cigarette smoking has also been linked to the increased occurrence of respiratory tract infections during the first year of life of the infant. Children from the low socioeconomic status tend to have more respiratory tract infection. We saw that people residing in who are having a low socioeconomic status, they will have reduced facilities. They cannot have a good access to the hospitals. They will live in a overcrowded places. The indoor smoke pollution will be more. The health facilities also will not be available to them. Even if they are available, they will not be in a condition to afford them. So children who are belonging to the lower socioeconomic status will have more respiratory tract infection. The infection is more common in the preschool children who are attending the daycare centers, and those children who are attending the daycare centers, they have more respiratory tract infections. The infections tend to be more common in urban communities than in the rural communities. We see that the urban living, because of the crowding which is seen in the urban living, and also the smoke, the pollution, overcrowding, all of this, the urban living is causing a more incidence of the ARI compared to the rural living. The mode of transmission. All the causative organisms are normally transmitted by the airborne route. You can see most of the transmission is by the airborne route, as most of the viruses do not survive for the long time outside the respiratory tract. The chain of transmission is maintained by the person to person contact. Since the organisms cannot survive in the environment for a very long time, the transmission is maintained by the person to person contact. Moving further to the clinical features of IRI. Beginning with cough. A continuous cough that may produce mucus or phlegm. The patient can have a continuous cough. And then we have a running nose, that is rhinorrhea, which is a common symptom. The sore throat, pharyngitis, is again a common symptom of the upper respiratory tract infection. Shortness of breath can be there. And we have acute otitis media. Acute otitis media, which is infection of the middle ear, profuse sweating, And then fever. The fever, the high temperature, chills can be seen. The patient can have breathlessness, tight chest, etc. Moving further to the clinical assessment. I hope the clinical features are clear. Apart from these clinical features, we also have discussed in our like each of the individual risk factor, each of the individual agent and the risk clinical features, under which you can mention what are the new things you can mention. You can write down the patient can present with pharyngitis, and we have tonsillitis, nasal pharyngeal membranous exudate, severe toxemia can occur, and there is exacerbation of bronchitis, chronic bronchitis pneumonia. The patient can present with the severe manifestations. Under the heading of severe manifestations, you can note down lobar pneumonia, bronchopneumonia, then the other things, fever, malaise. It can be malaise can be added in it, influenza like illnesses, bronchiolitis, a common cold, influenza like illnesses, etc. Is it clear now? So the clinical features are very clear. Let's move further to the clinical assessment. History needs to be elicited. The history taking in clinical assessment, they are the very important factors in the management of the acute respiratory infections. So we need to note down the age of the child, for how long the child is coughing, and whether the child is able to drink. If the child is aged 2 months up to 5 years, we need to find out if the child is able to drink. And then, has the child or infant, young infant, stopped feeding well? If the child is less than 2 months, we need to find out if the child has stopped feeding well. Has there been any antecedent illness such as measles? Does the child have fever? Okay, we need to ask the history of the fever. If the child is excessively drowsy or difficult to wake up, and did the child have any convulsions, or you should also ask about the irregular breathing in the child. Is there any irregular breathing or short periods of not breathing, or the child is turning blue? Any history of the treatment during the illnesses have to be taken. Is it clear? The clinical assessment, what are we taking? The age, since when is the child coughing? Has he stopped feeding well? Is he not drinking enough water? Is there any history of the fever? Is he not able to drink? If he's aged up to 5 years, you can see if the child is not able to breastfeed, if it is 2 months and above. And then we have history of fever. We need to elicit the history of fever. If the baby is drowsy or difficult to wake up, if there are any patterns of irregular breathing, absence of breathing for some time, and then convulsions, history of convulsion has to be taken, and any history of treatment, or then is the child turning blue? We need to find out. Next, we need to look and listen to the following. Count the breath in 1 minute. Under the physical examination, we are starting the physical examination, wherein we will count the breath in 1 minute. As the children get older, their breathing rate will slow down. Fast breathing will depend especially upon the age of the child. So we see that as the children get older, the breathing rate will slow down. Therefore, the cutoff point used to determine if the child has a fast breathing or not will depend especially upon the age of the child. That is the reason in the history we ask about the age of the child. Under the physical examination, we will count the breaths in 1 minute. It should be seen for 1 full minute, looking at the abdominal movement or the lower chest, especially when the child is calm. The chest and the abdomen, they must be exposed for counting. Increased respiratory rate is of significance only if it is persisting for a long time. We need to find out that the respiratory rate is normal or not. So, let's see. Fast breathing is present when the respiratory rate is 60 breaths per minute or more in a child who is less than 2 months of age. So we see that fast breathing is considered if the child has 60 breaths per minute in less than 2 months of age. 50 breaths per minute if the child is up to 2 months to 1 year, and 40 breaths per minute or more if the child is aged 12 months up to 5 years. You see, 1 year up to 5 years or 12 months up to 5 years if it is 40 breaths per minute or more. However, we repeat the count for a young infant who is less than 2 months. If the count is 60 breaths per minute or more, we need to repeat the count. This is important because the breathing rate of a young infant is often, very erratic. So we repeat it. Occasionally the young infants will stop breathing for a few seconds and then they start to breathe very rapidly for a short period. So the breathing patterns is very erratic in them. So it has to be repeated. Next, we look for the chest in drawing. Look for the chest in drawing when the child breathes in. The child has indrawing if the lower chest wall goes in when the child breathes in. The chest indrawing will occur when the effort is required to breathe in is much greater than the normal. Is it clear? You can see that the chest indrawing, very nice picture is given. The chest indrawing is seen in the child. The chest indrawing, when does it occur? Only when too much effort is required by the baby than what is required normally. If he's putting in too much effort to breathe, then the chest indrawing is seen. We need to look for the chest indrawing in the infant. Next, we need to look and listen for the stridor. We see the stridor, a child with stridor will make a harsh noise when he breathes in. The child who is having stridor, he will make a harsh sound especially when he is breathing in. Stridor occurs when there is a narrowing of the larynx. You can see the vocal cord here, larynx. There is narrowing of the larynx, the swollen voice box, larynx and trachea because of the infection. This swelling, once the swelling occurs, there is a narrowing of the trachea or the epiglottis which is interfering with the air entering the lungs. This is called as croup. These conditions are often called as croup and the patient presents with stridor. What's happening in croup? There is a narrowing of the larynx or trachea or epiglottis and it is interfering with the entry of the air into the lungs. Next, we will look for the wheeze. A child with a wheezing will make a soft whistling sound. In wheeze, we have a soft whistling sound when the child will breathe out. Can you make the difference here? We have to see, we have to look for we will count the breaths in 1 minute. Then we will look for the chest indrawing. Then look and also listen for the stridor. Stridor, especially when the air is entering into the air. During inspiration, when the air enters into the lungs, the patient gets a sound. During inspiration, the harsh sound is seen, which is stridor. And wheeze, when the child is breathing out, a soft whistling sound is heard. And they also show the signs that breathing out is very difficult in them. The wheezing is caused by the narrowing of the air passages in the lungs. It is caused by narrowing of the air passages. You can see in the picture here, the air passages are being narrowed because of the inflammation, because of the infection of the upper respiratory tract. Then it is caused by the narrowing of the air passages in the lungs, the lower respiratory tract, and the breathing out phase takes longer than normal and requires much effort. We also need to elicit the history of the previous history of the wheezing. Is it clear? We need to find out the history. Ask the mother if the child has any previous episodes of wheezing within the past year. If the child should be classified as having recurrent wheeze. Okay, we need to find out in the previous year if the child had wheeze, or we need to classify if the child is having recurrent wheeze or not. The other signs, we need to see if the child is abnormally very sleepy or he is difficult to wake up, very drowsy. If an abnormally sleepy child is drowsy, most of the time when he or she should be alert and wake. Okay, most of the time when the child was supposed to be very alert, when most of the time he was supposed to be awake, he is now very drowsy, difficulty to wake up, and very difficult to wake him up, and abnormally sleepy. Next, we will feel if the child has a fever or a low body temperature. Feel for the fever or low body temperature, and also check for the severe malnutrition. Malnutrition, when present, is a very high risk factor, and the case fatality rates are much higher in the children. We see in okay, we also have the cyanosis, which is a sign of hypoxia. Cyanosis should also be checked, especially in a good light. The cyanosis, the purplish discoloration is seen. It is a sign of hypoxia. It shows that enough oxygenated blood is not supplied. It is need to be checked, especially in a good light. Next, we see about the severe malnutrition. We need to check for the severe malnutrition, because the severe malnutrition is one of the high risk factor for the case fatality rates. They are supposed to be high in the children with the malnutrition, because it is one of the risk factor for the ARI. In severely malnourished children with the pneumonia, the fast breathing, the chest indrawing may not be very evident, because they are malnourished. The chest indrawing could also be there, so we cannot figure out if the child is having pneumonia, especially when he's severely malnourished. It is difficult to rule out pneumonia because the fast breathing and chest indrawing may not be very evident in these children. A severely malnourished child may have an impaired or absent response to hypoxia. They might have an absent cough reflex, a very weak cough reflex. These children need a careful evaluation and management for the pneumonia. Next, we have the classification of illnesses. We will discuss about this. Okay, let's see if it's possible. We'll finish the classification, and then the remaining we will try to. Oh, classification is quite big, so we will discuss about the classification and the further topics in the part 2, the next session of the same video. Thank you. I hope everything is clear. If you have any doubts, put them down in the comment section. And if you like the video, hit the like button, subscribe, and share it to your friends.